sure they're connected in. Oh, great. Well, good morning or good afternoon, depending on where this broadcast finds you. I think we're probably all still in the morning hours. Just want to welcome you all to our fourth session of our Walking in Two Worlds Behavioral Health Challenges of Living in a Living Native in a Non-Native World. This is season 4. Today we will be discussing issues surrounding historical trauma and ACEs, or adverse childhood experiences. We've got two wonderful presenters, Mr. Ray Daw and Ms. Santos Gonzalez. Ray is broadcasting to us, I believe, from New Mexico, unless he changed locations on me. And Santos is coming to us from California.
Arizona.
Are you in Arizona now? Okay.
Yeah, I'm in Arizona.
You're just on, why did I think you were out all the way out west? Maybe it's that Pacific time. I think Arizona is Pacific time. So
yeah.
It might be a Freudian slip too, because you're wishing to be in California.
that's right. I'm almost there. I'm broadcasting today from Billings, Montana. So I'm a little closer than our home office at the University of Iowa in Iowa City. But Natasha and Teresa, we're really happy to have you here. We have a very small group today. We may have some others joining. I'll kind of watch the waiting room to see if we have anybody joining a little bit later. I want to turn the floor over for just a moment to let Donna Enfield, our IHS collaborator, say a few words. Donna?
Well, good morning, and I'd like to add my welcome to the two of you, and so glad that you're here. I've had the chance to look at the PowerPoint ahead of time, and it looks like some really, really interesting things that that Santos and Ray have for you today. I am working off site today, so I'm probably not going to have the opportunity to stay on for the whole presentation. I wish I could. But we're glad that you're here, and just look forward to a very good and very interactive learning experience today. Thank you.
Thank you so much, Donna, for being here with us. I know you are trying to be in two places at once this morning, so I appreciate your efforts. And this is an ongoing collaboration between the Native Center for Behavioral Health here at the University of Iowa and the Indian Health Services in the Bemidji area. So we're happy to have Donna on with us, even if it's for a little bit. My name is Steve Steiny. I'm one of the managers with the Native Center for Behavioral Health, and I come from an addictions background. Have my master's degree in counselor education, substance abuse. I'm a certified addictions counselor, and I've been in recovery for over 34 years. So, excuse me, I'm really happy to meet all of you this morning. We've got two wonderful speakers that I can't wait to introduce. I've got just a couple of introduction slides to go through, and then I'm going to turn the floor over to Ray and Santos so we can get started. So happy to have you here. Sit back and enjoy. There's a lot of great information here, and there's some interactive components as well. So we'll be asking you all to chime in periodically. So again, this is session 4, historical trauma and adverse childhood experiences with Ray Daw and Santos Gonzalez. So just a couple of reminders. This broadcast today is in collaboration with the Native Center for Behavioral Health. It's supported by the University of Iowa and the College of Public Health. The content of this event is the presenters. The opinions expressed do not necessarily reflect the views or policies of the Native Center for Behavioral Health, University of Iowa, IHS, HHS, or the College of Public Health. And I've got a single screen today, so I'm really moving things around to make this work. I miss my double screens, Ray. I don't know how I function without them. Just a note, we will be following up with you via email following today's event. You will get an email from us with a PDF copy of today's presentation slides. We are recording this event as well, so there may be a recording that you can access and share with your colleagues who may not have been able to attend today. And lastly, we'll be offering NADAC approved CEUs for substance use disorder clinicians or social work CEUs if you are looking for social work CEUs. So you can request those CEUs at the time that you receive the follow-up email. I know we're gathered here virtually today, but I would like to take a few moments to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a few moments to read this land acknowledgement that was created by 3 members of our team here at the Native Center for Behavioral Health, Keely and Ella Driscoll, and our co-director, Mr. Sean Bear. Thank you. Well, without further ado, I want to introduce our speakers today. First, I have Ray Daw with us. I consider Ray a colleague, but more importantly, a friend. And Ray, as I said, is broadcasting to us from New Mexico. Ray is part of the Navajo Nation, and he is a senior consultant with our center. And he's got a wide range of clinical experiences and has worked in the field for many, many years. I'll let Ray talk a little bit more about some of his clinical background, but we're really thrilled to have him here with us today. Ray, it's great to see you, and thank you for joining us. I also have a new colleague of mine, Santos Gonzalez, who I have had the privilege to meet through my relationship with Ray. She is broadcasting to us, as I said earlier, from Arizona, and she has her Master of Social Work from Washington University. And since she's graduated, she has worked in mental health and behavioral health fields. She's a licensed independent social worker and is currently working as an adult clinician with the Apache Behavioral Health Services. We're really happy to have her here. She's got a wealth of knowledge and experience, and I know her schedule is very tight because she's involved in direct services. So having come from that background, Santos, I can respect and appreciate you taking the time out of your busy schedule to be here today. So thank you so much, and really happy to have you on the webinar today. So I will let Santos talk a little bit more about herself, but I know that she is affiliated with the Cherokee and Blackfeet. Also has some Hispanic Latino heritage, as well as some European and African heritage. So she's got all the bases covered. Really happy to have you here, Santos. I'm going to go ahead now, and I will be advancing the slides today. So just rather than stopping the share, I'm just going to forward this. There we go. So I'm going to go ahead and mute and turn it over. I don't know, Ray or Santos, who's leading this off, but the floor is yours. Thank you.
Okay, thank you. So Ray, did you want me to start with the objectives?
Well, I'd like to change it up a little bit and give opportunity for Teresa and Natasha to introduce themselves to us. so that we can get to know where you're from and what you do. And important for me is to hear of your experience on the topics that we're going to be sharing about. So Teresa, maybe you can begin.
Honey,
Good morning.
Teresa Subrell. 3 names. Chinakazud is my most current, but my dad had 3 names before he passed away.
Mm,
Um, and I'm traditional name, and it started out there for me, working, living in Indian country, just in our ways with the people, and then through education and circle. So I think this is such an important topic, which you guys are covering today. This is one of our hugest issues. I feel that our people are stumbling on this because of trauma response. They're attaching all of their perspectives just about their moments in life, their incidences, their parenting, their relationship, their perspectives and views on everything is being translated through experiences. So this is very important that our people learn about this, whether it's those going through it or those working with the folks going through it. So thank you guys, Miigwech, for what you're doing here today.
okay. Natasha?
Looks like she doesn't have a mic, Ray.
Mm,
So she's just introducing herself in the chat. She says
Okay.
social worker at Cass Lake IHS Service Unit. She says, I agree, this is absolutely an important topic.
Cass Lake IHS. Okay. All right. Go ahead, Santos.
Okay. Go ahead, introduce myself again, or?
Yeah, go through the objectives.
Okay, I wasn't sure because this screen changed. So the objectives that we're going to be covering is defining trauma, describing adverse childhood experiences, and describing historical trauma.
Mhm. Okay. So for the first objective, which will be around defining trauma and looking at it from a couple of perspectives. Our purpose here is to review what trauma is and how it is described. I also asked Teresa and Natasha, when you have opportunity, just go ahead and let us know when you want to make a comment or put it in chat, because we have opportunity to be interactive here. Okay. And so I'd like to take an opportunity to do that with both of you, and Steve also. I want to forget my brother here. So go ahead, Steve. So we'll begin with a question. And the question basically is, what trauma experiences do you encounter in your community? Teresa and Tasha, can you take that on?
Natasha's going to be writing in the chat, correct?
Okay, yeah.
So I'll jump on then. And in the community, I would say definitely abandonment issues and addiction issues. There's definitely a relative, if not themselves. There's sexual assaults, if not themselves, a loved one. There's physical abuse, verbal, so much verbal abuse, bullying, lateral violence, I think is the most prevalent, and morals and values, and how they've been redefined today by trying to survive in what's become the norm. And so I noticed that a lot of dissonance through the cultural changes of teaching that's changed again how we interact and behave, and it spirals out where it causes problems, because you're not going to get the good fruits of that when you think that's what's okay and normal, and you don't understand what did you do wrong. And so a lot of racism, so a lot of trust in getting help, in trying to reach out for help. So re-victimization that way as well. That's just to name a few, but I think the most prevalent ones that are the biggest issues. Miigwech for asking.
Okay, thank you. Natasha? Okay.
So we see a lot of the same issues. I would say children being raised by grandparents and not having the relationship with parents could be due to substance use, abuse, or a parent being in jail.
Great. Well, comments are in sync. Go ahead, Steve.
Okay. So we're going to be defining trauma. So cultural trauma is an attack on the fabric of society, affecting the essence of the community and its members. Historical trauma is cumulative exposure of traumatic events that affect an individual and continues to affect subsequent generations. Intergenerational trauma occurs when trauma is not resolved, subsequently becomes internalized, and is passed from one generation to the next. And then present trauma, what vulnerability Native peoples are experiencing on a daily basis. And this information comes from D. Bigfoot. And so there's kind of some basics there with defining trauma.
Yeah. Trauma has three features to it from the American Psychological Association perspective. First is emotional trauma to an event, and usually immediately after a traumatic event, and it's somewhat common to experience denial and shock. Then we have long-term reactions that include flashbacks and emotions like fear and anger that may include affecting our relationships with others. And I think we read and heard from Teresa and Natasha some good examples of that. The third thing are physical symptoms that come from traumatic experiences, and these some of the more common symptoms are headaches, nausea. And these are normal responses to life-changing traumatic events. I think we're becoming more cognizant of that normality of how our responses can be that way, particularly with headaches and nausea. So I thought we'd share this description of trauma from the APA. Go ahead, please.
And so it kind of continues, and it says, how do I know when I or another needs assistance with trauma? So, some people may experience difficulty forgetting or moving past their experience and getting on with their lives. They may experience fear or other difficult emotions that emerge unpredictably. These emotions may affect their lives and those around them and interfere with relationships with others. They may have bad dreams, nightmares, or kind of hallucinating related to the traumatic event. Possible persistent feelings of hopelessness or distress, which may interfere with daily life functions, responsibilities, or those activities previously found enjoyable. And so again, this comes from APA. And in some ways, these are kind of like some of the criteria, that like PTSD diagnosis touches upon. Some of these things will overlap in terms of like how we define it and how we see it with other, mental health diagnoses.
Good. There's some risk factors involved with trauma. As we're describing earlier, having previously experienced a traumatic experience. Stress can be included as a risk factor. The more stressed we are at the time of a traumatic event, that can influence how we respond to that trauma. And then as we'll have some discussion on later, we see that traumatic events as a child increases the risk to experience further trauma. And that's how that can be understood and then carried over into adulthood. Go ahead, next slide.
So trauma can be passed to family members through interactions with survivors of trauma. So not only children, but parents, aunts, uncles, grandparents, and other significant relationships that we may have. Trauma can also be passed through genes. So it kind of starts to become, hereditary. And then this is intergenerational trauma, which can be traced back, decades through family. I think I just saw a chat, but I don't know what it said.
Yeah, Steve comments that trauma is a primary issue with 90% of his patients. Yeah. Were they native patients or a mix of native, non-native, or non-native patients, Steve?
These were primarily non-native patients. Some ethnic diversity, but primarily non-native.
Okay.
With a wide range of age.
You kind of faded out there. A wide range of
age.
Okay. Well, thank you for the clarification.
The next slide.
Trauma can be passed to, PTSD as seen from the brain, as seen in the brain, and it can be healed. Repeated effects, the effects of exposure to trauma in childhood that has been repeatedly linked to the development of maladaptive traits and personalities. I remember Dr. Volkov, who's the director of NIDA, talking about the impact of trauma on the brain way back in the mid-1990s. So Dr. Volkov, as a clinician, as a researcher, brought this to the forefront almost 30 years ago and has really been consistent on this issue. So it's been one of the pleasing things and that I've seen within the NIDA is the acceptance of this. Go ahead.
So when we think about, Native populations specifically, American Indians experience traumatic events at higher rate than what was previously reported in the general population. So, we tend to have more experiences of traumatic events than other ethnic groups.
And there's some references there for you to look at later on if you have time. Go ahead, Steve. There you go. Some root causes. Are these eight things, and it can be more also, but I thought we'd highlight this in light of the topic that we're working on with ACEs and historical trauma. But this is something that we are commonly aware of, I think. And for Native people in particular, I think the one on rigid religious practices has had a profound impact. Next slide, please.
So when we think about acculturation assessments, acculturation assessments allow for providers to assess the cultural identity of a patient, which can help the provider to gain a better understanding of the cultural context in which the symptoms are rooted. So additionally, whether a patient identifies as traditional or bicultural or acculturated, it may have an impact on their treatment preference. And over time, correct placement may be made as self-reports may not always be accurate tribal knowledge. So what this is kind of getting at is, kind of understanding not just, the symptoms or the root causes or experiences they're having, but also looking at, what is their culture? What is the context? Kind of like, the person and the environment, and kind of taking all those pieces together when we're engaging with a client, in a clinical setting, or really just kind of in any interaction that we're having.
Very good. Thank you. Next slide, please. think we are aware that acculturation is on a continuum. It's not a set point. And as a continuum, there are a lot of factors that we can look at for when talking about acculturation. You know, how we dress, how we speak. You know, an example here is if I look at Navajo from a cultural perspective, I'm more acculturated to Navajo when I'm speaking Navajo in ceremony, and unacculturated to the Euro-American ways. On the other hand, if I'm sitting in San Diego with a meeting with a lot of people, then it'll be primarily in English, and so I'll be acculturated in the more acculturated in the English way, and less acculturated in the Navajo way. This is how the acculturation process works for many of us that work in multicultural settings. Thank you. Next slide, please.
So another question, you know, what types of acculturation have you seen or experienced within your communities?
Teresa?
Or taken away from her crafts?
What I've seen a lot is, well, due to residential school and the soldiers, when they first came in, our ceremonies were outlawed. You were shamed. And then I think a form of Stockholm syndrome, many that came back, or in fear of repercussion to their loved ones. We didn't talk about our culture. We didn't talk about our teachings. And so when it started to come back, it came back with a lot of folks who endured traumas like residential school, and that they were mixed. The sexuality, perversion, paternalism, chest thumping, degrees, and ritualistic forms. And it changed a lot and creates a disconnect where the folks have a hard time feeling it when they go in and they think there's something wrong with them. So I see a lot of a culture that. And then also, you know, the powwow, how that's changed. And I see a lot of those changes to that again, and it's just not doing it for them, they would say. Become acculturated as well. And it's the real meaning of the words, the language, the power in those, what's in it is gone. For the completely gone. They're just not finding it right now. And then it's name brand stuff. We were such people of individualism, and everybody has to look like the cookie cutter to define success. And we all got a white pickup truck, or we all got a black pickup truck, or we all whatever reserve I've through, they will have their trends. And so they're just defining what they find as success. They've lost what's really successful and matters, and finding their peace.
Yeah.
It's like order where there's just not enough an addiction.
Thank you, Teresa. It's always a joy having you online, Teresa. Thank you. Natasha, do you have any comments in the chat you'd like to share? Okay, Steve, next slide.
Okay. So now we're going to kind of get into describing adverse childhood experiences, or ACEs. And so the purpose of this is to look at how childhood trauma has negative consequences, and ACEs kind of helps to explain some of those impacts. So next slide, please. So another kind of question, and some of this I'm sure will be kind of overlap from some of the previous questions, but how would you say that you encounter instances of ACEs within your community?
I have noticed there is so many health issues due to trauma. You know, there are a lot of a lot of stomach ulcers, a lot of blood pressure, heart disease, diabetes from comfort food eating, and the soldier fort rations that we now have are the cultural diet. Induced depressions and chemical imbalances due to diet changes. So kind of how you would over respond or under respond to things. The energy drain, it just kind of takes your will or wanna, between what you're going through or your loved ones are going through, or the lateral violence. So all the different steps and sources throughout their day that they're going through it. So with the ACEs scores, it's just off the charts, because coming from so many different sources, plus what you grew up in, depending on the age where they're at. You can grow up in a healthy home with loving parents that have tried to break the cycle, and these kids are going to school and then getting traumatized by kids who are coming from where there's sexual abuse. So that kind of talk is taken away. There's that as well.
I see. Thank you very much, Teresa. And Natasha made a comment to us related to the first question. She made two comments now. Thank you, Natasha. Natasha says we don't see as many who still speak the language. This is related to the acculturation question. And there are still some who do, and she thinks it's great that the local schools teach language and other aspects of Ojibwe culture. And I think it is important for a younger generation to feel connected to culture. Thank you for that. Related to the question on ACEs, she works in the hospital, and she sees a lot of the physical and medical symptoms of individuals with high ACEs scores by individuals. Thank you, Natasha. Go ahead, Santos.
So when we think about, the ACEs, so childhood experiences, both positive and negative, have a tremendous impact on future violence, victimization, and perpetration, and lifelong health and opportunity. So as such, early experiences are an important public health issue, so this is coming from the CDC. And so when we think about, the native model for trauma, is historical trauma. And so, ACEs came to the forefront in describing, how those experiences can cause mental, emotional, and physical health problems. We look at ACEs as having become a widely accepted approach to understanding trauma and its negative relationship to well-being. A lot of different organizations and agencies have started to apply the ACEs concept in funding and services and training. So things like, CDC, SAMHSA, education, different juvenile justice, or even correction systems, we're trying to implement how do we kind of take what we know about ACEs and how do we kind of use that to help the individuals that we're serving. And so when we think about, the ACEs in terms of like measurements and validation, many natives believe that the ACEs measurement validated what many in Indian country have already advocated, that unresolved intergenerational trauma is a significant contributor to social and health disparities among tribes. Some of this is coming from, Dr. Bigfoot's, work that she does in, her community in Oklahoma, and she does a lot with childhood trauma. She does a lot with adapting, kind of like Western mental health models into more like a culturally appropriate form. I know that she's adapted PCIT, so parent-child interaction therapy, among others. And I think that us looking at how the ACEs, impacts all these different areas is, pretty vital. Next slide. So this is just, kind of a infographic, I guess, in ways of when we think about the ACEs, the questions and how they're split kind of touch on these three main categories. So, there's questions about abuse specifically with physical, emotional, and sexual. There's questions about neglect, so physical and emotional neglect. And then the last grouping of questions kind of fall under this category of like household dysfunction, right? So is there mental illness, or is anyone incarcerated? Mother treated violently, kind of looking at, did someone experience or witness domestic violence? Was there substance use? Was there divorce or separation? And when we think about this, these things are clustered, which I think sometimes can be really helpful to see it in this way and not just kind of like the wording format. The words are important, but also I think, this really kind of like has more of an impact, I think, when we see it. And so let's see, I have some more stuff in my notes. So these are 10 prominent childhood traumatic experiences that are screened for in the ACEs, which are very common. So in the original study, which was predominantly middle class, white individuals, the original study had over 2/3 of the sample had at least one ACE score, and 1 in 10 in that sample had an ACE score of 5 or more. And so we know that the higher the ACE score, the more correlation there is to, physical and mental health, outcomes that aren't typically on a positive trend. Next slide, please.
Mm-hmm.
And so kind of speaking to some of that, like physical elements that we see, and some of you guys already touched upon, as their ACE score goes up, so does risks for certain diseases or injuries. So sexually transmitted infections, including HIV, gynecological problems, heart disease, diabetes, stroke, cancer, suicide. These are all kind of health outcomes that we see more of in communities where ACE scores are higher. Next slide, please. So when we think more specifically about our Native communities, we tend to have a lot more health disparities. So, some of our major ones, which you guys touched upon, diabetes, adult obesity, homicide, alcohol-related deaths, youth obesity, influenza and pneumonia. Moderate disparities, we have suicide, and then in terms of like lower disparities that we experience, infant mortality, smoking, I'm guessing this is like a lack of prenatal care, and then childhood vaccinations. And when we think about, our Native populations, like re-traumatization is a key concern. So health disparities exist and can complicate that patient-provider relationship. And sometimes this can create distrust and hypersensitivity from Native clients or patients that can complicate doing effective trauma-informed care. We have a pretty long history of not having the best relationship with providers, with the government, with not always being informed about what is or isn't happening to us in specific, studies and such. So there is a distrust of the, health community a lot of times, and some of that is rooted in truth, right? Having that healthy distrust because we're not always sure, what are they really doing? Is this really something that's good for us? Or, can I trust this person? And so I think some of that, does play a role into why some of these health disparities are at the levels they are, because a lot of us tend to avoid going to the doctor, right? We don't want to go to the doctor. It's kind of like you have to drag us, kicking and screaming to go. And so, some things that maybe were minor may kind of develop into a larger issue by the time that we're actually seeing. And then, kind of touching upon, I think what Teresa was saying, about kind of like changes in our natural cultural diets, we have a large influx of diabetes due to, the heavily processed foods, diversion of water, commercial tobacco, a lot of different things that weren't part of our communities originally, that now, again, that kind of acculturation that we've moved towards, that typical kind of like American diet and things, and then we're not as active, right? So a lot of those health disparities kind of just increase.
Can I make a comment here?
No comments.
Yeah, I read a report this morning that even on highly vaccinated reservations right now, we're seeing increases with COVID infections. Like Navajo, we have about 80% of our people fully vaccinated, and we're seeing about 100 new infections a day here on Navajo. And thinking about it, I attribute that to what we're talking about today. These health conditions that we're seeing have a major role in reducing the wellness of our immune systems. The more stressed you are, the more depressed you are, plus diabetes and alcohol abuse and smoking and not eating well, basically, it reduces your immune system. And even if you're fully vaccinated, if you get exposed and you're fully vaccinated and have a strong immune system, the chances are that you're not going to get an infection because of a strong immune system. So I think there's that correlation going on that researchers really haven't gotten into yet. But we're seeing some impact on this on the pandemic, I believe. Thank you. Next slide. Go, Santos.
I think you were gonna take this one. No?
Oh. All right. Mhm. The as we've heard earlier in our presentation, there are some lifespan impacts of ACEs, and as I alluded earlier on, Dr. Volkov's strong concern around lifelong impact of trauma, particularly childhood trauma. We're seeing this show up and how we describe ACEs impact. Adverse childhood experiences does have a role in brain development, how well the brain develops, and then that shows up in how the hardwiring, how our synapses and our brain cells function, and makes us more responsive, less responsive to trauma in our lives through our anxiety reactions or our depressive reactions, basically how it is. And then there's intergenerational transmission, the biology that happens and contributes to the disparity that we see with chronic disease, psychiatric disorders, and crime and poverty, for example. So this is what they refer to in much of the field as epigenetics. Okay, and there's more interest in epigenetics in the clinical settings that I'm aware of. Thank you. Next slide.
And then I know a note that because you said you couldn't see the notes. It said clinicians sometimes forget that the client adapts to their life experiences and their brain adapts also, right? So our brain development, makes us who we are emotionally, intellectually, and psychologically. And when we think about, kind of like those short and long-term effects, this can cause a shortened lifespan, as much as 20 years for those who have an ACE score of 6 or more, right? So when we think about that, and if you think about if that kind of passes down and just how your life, may be when you're kind of operating in this really like survival mode all the time, it does make it hard for you to, engage in certain experiences that might, change that outcome. And so that's kind of just another thing that I wanted to note.
Yeah. Cool. Next slide, Steve.
So when we think about, how do we kind of overcome, these adverse childhood experiences? So stable, nurturing relationships with caring adults can prevent or reverse the damaging effects of toxic stress. So it says thinking will not overcome fear, but action will. So, there are things that we can do to, kind of modify or reduce the likelihood that, the predicted outcomes are going to be the outcomes. Next slide, please. So I wanted to kind of touch upon, like the clinical impact of ACEs. And so when I look at ACEs, it does kind of two things. So one helps to focus like of the treatment of the patient, client, whomever you're working with. But also it helps us in kind of understanding our own reactions to ACEs. So from a clinical perspective, understanding the ACEs experienced, directly connects to what's addressed in a treatment setting. Oftentimes it may help us to just kind of know certain events that the client experienced. Even if they haven't made those connections, it can be helpful for us to then kind of have that, bird's eye view to start kind of understanding and helping the client maybe to understand why certain reactions are certain reactions they're doing, and why they maybe are having such a response when, their aunt or cousin or someone does something to them that they maybe, it could be a pre-verbal memory, right? It could be a lot of different things. And so just kind of knowing that information can really help us when we're targeting, specific events or traumas. Let's see. So another thing to kind of note when it comes to like understanding our own reactions to ACEs, sometimes could be recognizing that we might have our own kind of stuff that we need to work through. And that when we're able to recognize that, it can help us to feel less uncomfortable, asking certain questions, because we don't want to shy away from, obtaining information that's going to benefit our client just because we have some kind of like, feeling about asking this question. And let's see. So that's the point on those. So then the next slide. And so one of the things that I know that I use at my agency and that we've been kind of adopting since we've kind of been using the ACEs more within our screenings is to pair it with a resilience questionnaire. And so this is just an example of one resilience questionnaire. I'm sure there's many out there, but the idea with this is that, when we think about ACEs and a lot of our screeners in general, they're really deficit based. And so kind of being able to, ask the ACEs, but then pair it with a resilience questionnaire, which highlights, their resilience and also, maybe positive experiences they had in childhood, so that it's not just, okay, tell me about all the horrible, terrible things that you experienced and just kind of leaving it at that, right? So I like to kind of pair it with the resilience questionnaire because it helps us also to see, what are their strengths that we can kind of start with and pull from. And so next slide, because I think this one's a 14 questionnaire. And then at the bottom, it kind of says, you tally up how many that you noted were definitely true or probably true. And then of those, kind of noting how many are still true for me. And sometimes even this in itself can also be, different areas that we may touch upon in therapy about, well, what maybe changed if you had felt that it was true before or not true, or also even just looking at, what are some of the ones that maybe weren't true, but now you hold to be true. So this can be a really powerful tool as well, kind of looking more at like from a strengths-based perspective, and not just, okay, this is a negative thing that happened to you, and let's kind of look at it from like a, like a medical model, kind of like symptomology type mindset, which is often, that's really how that's how the DSM is written, right? Because it's written by medical professionals, right? It's not written by social workers or counselors. It's, it's the American Psychological Association, and they're trained medically, right? So it's that mindset of like symptoms and like medical model treatment kind of fixes, and not really looking at strengths all the time. So I like to pair this because I think sometimes it can not necessarily lessen like the impact of the ACEs score, but I think it helps the client to then see, okay, well, these are some good things I had, and this is what I can kind of like build from.
Yeah, and I really like the way this process works that Santos described, because there are historical traumatic experiences that come to us, but we also have historical wellness, I think. It's nice to bring both to the forefront. So thank you for sharing that. And Steve?
Teresa, I see your hand is raised.
Yeah, I like number 12, where it talks about people noticed they were capable and able to get things done. That's a good one because I've noticed, due to being in survival mode, your priorities change when you're in survival mode. It almost is narcissistic, like where it has to become about you. You have to, and then it's comfort food and self-care need up in a spiral. And then we have trauma bonding going on because it's become such a norm. And it helps get through, build up those walls, desensitizes, and again, becomes more of a norm. So we have the generational trauma. So because of this, the focus has gone off in such a direction that, when you look at developmental skills, whether it's relationship skills from infant up to senior, to budgeting, life skills, normal daily tasks, how to make a meal, how to meal plan, how to self-care, self-love, healthy boundaries. Our people are missing it in spades. So we have adults back into treatment centers, their 5th time through, and not having success because when they come out, they don't know how to budget and life starts falling out around them. They don't know what is the priority because they're still in survival mode. So those priorities are off. So I think that one's a really great question on your questionnaire. Add that.
Yeah,
So,
thank you. Okay. Next slide.
really great section. Thank you for sharing your teachings with us, Santos. Now we move on to the third section of the time we have together, which is with looking at historical trauma and our cultural connection to the heart healing. Our purpose here is that Native Americans have generations of trauma, and that can be discussed or within the context of healing and wellness. So that's where we'll go with this. Natasha, once again, if you have any comments to make as we're going through this, please let us know in chat. Okay. So we have another question here that we can all respond to, including Steve. What are some community historical trauma experiences that you know of? Teresa?
Definitely the residential school, orphanages. Up here, community-based, it would be like the spearfishing, the walleye wars, and then those protests. So all ages are out there getting spit at, shot on, called names, and surrounding community folks. So I think that's some really important ones.
Okay. I see Natasha making a comment in agreement with you, Teresa, that boarding schools are significant and are significant historical traumatic history. Thank you, both of you.
I mean, I think something I would add, just from multiple perspectives, right, is just the idea of reservations in general, right? A lot of tribal communities, are not in their original homelands, and maybe they didn't have a set homeland, right? A lot of tribes were kind of, more nomadic. They were more, they weren't as fixed. And so a lot of that, I think, can also be, historical trauma. Thinking about other perspectives, just from like my own, like multicultural background, I think about like my mom is white and Black, and, I think about like slavery, or, I think about with my part of my dad's family, with just like being, like a first generation, different kinds of things like that. I think that, sometimes they still play a role, right? But I think reservations themselves, are very traumatic.
Yeah, very true. And there were reservations or internment camps, basically, in many. Yeah, good point, Santos. Thank you.
Teresa wanted to say something, I think.
To add to that, we were by season, we moved around, and our reservations or reserves are more marshlands. So you're looking at mold, things like that, and how mold impacts health, mental health, and then it's also spiritual health issues and what spirits prey upon that. And how can our people go to a therapist and talk about that without being written off as crazy or feeling comfortable or understanding? And the third part is a lot of people, including our own, doesn't understand, because some of the last residential schools were closed in the 70s and like the 60s scoop and orphanage trains and things like that, don't understand. They say, well, that didn't happen to me or my parents, even though it was my father who was a residential school. A lot of folks, it was their grandparents. So they don't think it really applies to them, but they don't get how it was such a cultural shock. And then the drinking that occurred, because back then you don't talk about those things, the night they were having, and then the repeated abuse. So how does residential school affect our people today? It definitely does.
Yeah,
So
right.
then diabetes, when you're in survival mode, a lot of people don't think about how does diabetes really impact a person when you can't think clearly. Your energy is zapped when you're so to really talk about the symptoms of it and how it's affecting folks, right? Like, thank you.
Yeah, thank you, Teresa. It occurred to me that one of the impacts of the pandemic and COVID infections are the long haul symptoms, and how that has has a role with how we're seeing across many communities of color in more drugging and alcohol abuse and psychiatric problems and violence. When we're feeling a lot more, when we're feeling a lot less well, then these kinds of behaviors, I think, increase. And I think long haul symptoms, which is described heavily, I think may have a role in that today. Thank you. Next slide, Steve. When we introduce the topic of when we get into the topic of historical trauma, we always show the definition of historical trauma that Maria Braveheart and Myra de Bruin developed back in 1998. It's a legacy of chronic trauma and unresolved grief issues. And that's where ACEs begins to have shows up, I think, is around the legacy of chronic trauma and unresolved grief across generations, and which are enacted by the European dominant culture. Next slide, please. Some examples of historical trauma, and I want to are the Nazi Holocaust, which is severely traumatic experience for not only Jewish people in Europe, but also many other cultures. During the World War II, and every conflict there is within it has holocausts. Basically, the genocide and just a mass slaughter of people. We have our American Holocaust experience, covering over 500 years. In fact, when Adolf Hitler was contemplating how to deal with Jewish populations and other populations that were coming under his control, he looked to how the United States and English dealt with American Indians and South Africans, and creating his concentration camps and forced migration of people that he didn't want within his within the areas that he took over. Next slide, please. When Maria does her presentation, she always shows these slides, which are always significant, because this is a way of grounding ourselves in terms of what historical trauma is. And you'll see the relationship to the historical trauma perspective and the ACEs perspective. There's a really strong overlap, like the symptoms that are described here. And what cuts across the emotional, physical, and psychological impacts and things like what Teresa talked about around changing in laws for environment, and that makes many of our practices illegal. Has a role in historical trauma. Next slide, please. Want to describe that map there?
Oh yeah, so I chose to kind of include this map. If you go back, sorry. You know, so again, we've talked about boarding schools, we talked about residential schools, you know, and from 1819 to the present, there was 357 boarding schools run by the US federal government and churches, and 64 remain open today. I'm not sure exactly when this was, you know, this image came from exactly, but you know, there's still, like we already spoke about, you know, a large impact from, you know, what happened there, even just the trauma of being, you know, forcibly removed, because most children weren't, you know, sent willingly. You know, a lot of times there's a lot of threat and coercion, you know, used to take children, right? To if you don't give me your children, you're going to starve, or you know, a lot of different things where sometimes, you know, there really wasn't a choice. You know, and we know what's happening, you know, north of the border, you know, with our relatives in Canada, you know, with everything coming out, you know, about the mass graves and all of those things, you know, those themselves are, you know, again, just kind of reiterates that historical trauma experience. And then, you know, looking at how there's still a lot of these in operation today, you know, and a lot of them, I would say there's still, you know, some practices I'm sure that are going on that happened, you know, in the 1800s that are still happening now.
Good. Thank you. Next slide. Back in the late 90s, when Maria was working with Dr. De Bruin and others on creating a historical trauma model, they recognized that trauma is passed through generations, genetically and biologically and psychologically, through the education system, the environment. And that and they also recognize that that warriors among our people and healers among my people had special spiritual powers, that abilities that allowed our people to go do things that are considered almost supernatural. Like many of our native people who join the military are considered to be are special in how they are as Native people joining the armed forces of not only the United States but Canada, and consequently our language and our warrior ways are incorporated into many aspects of contemporary military society today. Code talking and things like special forces derive from Native practices, really. Thank you. Now we get to the crux of the historical trauma model and the way we work at teaching and understanding historical trauma. There are four intervention components to the historical trauma model. The first part is confronting the historical trauma and embracing that history that comes from that trauma. The second intervention, and these are real interventions that Dr. Braveheart and her team cover when they're doing a trainer-trainers process. The second intervention is understanding the impact of that trauma. And we had some discussion on that already in previous slides, especially within the ACEs section. And the third intervention is about releasing our pain and not carrying that hurt, that anger, that depression, that anxiety within our physical being all the time. It's about healing from it and letting it go, and keep having processes to do that. The fourth intervention in the historical trauma model is about transcending that trauma, living a life that isn't as impacted and influenced by the trauma that our people have experienced and that we've personally experienced in our lives. And these are the four interventions that we very carefully work on when we're talking about historical trauma. And the thing that Maria always hits me with is, don't always talk about the trauma, Ray. You got to mention that there's a way from that. There's a healing path from that. And we have these four interventions that she designed very well to begin to move us through a healing path. And this is the crux, as I mentioned, of the historical trauma model. Thank you. Next slide.
So this map was one that I wanted to share because I really like how, it starts to show, oh, you went away. I like how it starts to show, I mean, I don't know how well you can see it, but all the different, tribal communities and nations, and really a lot of that overlap, right? Of how interrelated we really were. Because I think a lot of times, when we think about our communities, sometimes we can kind of get into this siloed thought of like, okay, well, we're this separate or other things, or that's even kind of, I think, what the government, really wanted to do was to disconnect us. And so this comes from nativeland.ca. And so, you can kind of, there's a lot of different great information with that website and organization, but I really like that it kind of shows all the, overlay of the communities, and just kind of wanted to, highlight that here as we talk about like confronting historical trauma.
Yes, and then I'd like this map a lot because it shows how we shared a lot of the lands that were given to us. When I was in San Diego, Steve, I mentioned to a couple of people that for my people, Navajo, way out in New Mexico, near Albuquerque, how Catalina Island, which is off LA, is one of our most significant sacred places. And Catalina Island, offshore from the LA area today, and about 600-700 miles from Navajo land, remains one of our most sacred areas. And so our land use practices extended that far. And that was a spiritual use, not necessarily for hunting and fishing and gathering. So I wanted to make that point also. Next slide, please. Thank you, Santos.
Mm-hmm.
The process of colonization really points out the impact of the doctrine of discovery that came out when the Spanish began to basically take over many parts of native country, not only in South America, but in Central America, Mexico, but also in the United States, the northern continents, and how that influenced not only how the Spanish and Portuguese, but also how the English and French came across in their attitude towards native people, which was to force natives out of their traditional homelands, and where they could, and turn tribes after conquest occurred, and also to begin systematically repress our practices, beliefs, languages, and identity, which we see showing up today, as Natasha mentioned, and language, and how that overlays and what the Euro-Americans describe as a manifest destiny. These two things really have an impact. The doctrine of discovery is a written document from the Catholic Church, and the manifest destiny practices which are described there come from that, and we still experience that today, I think. And what you see in the picture is a picture of my people who we were interned about 300 miles from our traditional lands. And visit chat here. Thank you, Teresa, for your comment on the slides. Any comments, Santos, or can we move on?
Yeah, and so I know I had included, manifest destiny on here, right? Because, kind of in short terms, right, that was like, westward expansion, which the US government kind of said was like, divinely ordained, right? They kind of used religion intertwined with this westward expansion, which kind of, helped justify and rationalize, removal of native populations from their lands, right? And so entwined with that, it also affected other communities, but, that was a huge kind of like momentum, that happened under Polk's era in like 1845 to 1849. He was kind of really one associated with manifest destiny, westward expansion, and all of kind of the changes that happened in at that time, like the quote unquote undiscovered territories. So yeah.
Thank you. Next slide, please.
Teresa wants to say something.
Okay, Teresa.
We talked about the moving of our homelands and the changing of our relations. It made me think about, that's right. For example, over by Lac du Désir, there's a garden on the lake there, an island. And our people, we were broken up by clans, not by reservations as an Anishinaabe. And Menominee, we're so closely related to Potawatomi. There's a handful of tribes in our nation. So over in this area, it would have been Ottawa and Menominee and Potawatomi, and we would come on certain seasons over by that garden together as a people and sharing stories, brotherhood, sisterhood, game playing. So the kind in the relationship build those dopamines and all those good chemicals, love and that coming together and that support, and then the healthy foods. So all that it encompasses. Whereas today, because of the separation, we're identifying ourselves as a people as a reservation, not as a people. And not coming together, are coming together when our reserves or tribes come together, it's usually about something trauma-based and based. So it's not cultural based like it used to be. So that also has an impact, and I think is interesting, more trauma bonding.
Thank you, Teresa, for describing that. And you're absolutely correct about that. Thank you. Next
So I
slide.
know Natasha asked me to share the link to that map. I'm going to message it to Steve, and then he can post it in the chat, just because I can't really do that from my iPad because I have the slides running on my laptop. So I will get that to you then, Natasha.
Okay.
I had mentioned that mapping tool to Teresa as well. I think she's interested. I think she would find it fascinating. Searches, and it's all it's wide too. So I was even some of my Northern European heritage and some of the indigenous tribes in the Scandinavian areas. It's absolutely
One of the questions that comes up regarding the doctrine of discovery and manifest destiny is how the European practice of colonization happened here. But also an important question that comes up for me is, how did that develop historically? So for my learning, I've looked at, in particular, the Roman colonization of many of the European countries, not only Spain, France, but also into Great Britain, and now into Norway, Switzerland, and basically a lot of the Eastern European countries were colonized by Europe, by the Romans in Constantinople, and all the great wars that happened with the Mongols and the Muslim people over the centuries. And such violent, brutal practices developed out of that just kind of came out, I think. And so I wanted to share that piece of learning and teaching also. Thank you. Next slide, please. This one is a phrase that I include in my presentations regarding understanding the trauma or confronting the trauma. This is a billboard that was in the middle of the Navajo Nation capital back in the early 1950s. Imagine a billboard the size of probably 12 by 4, sitting on a major intersection in the Navajo Nation, were these words put up by the Bureau of Indian Affairs. And it sat there for many years, that what the BIA was teaching and enforcing to our tribal leaders on that was that tradition is the enemy of progress. So this is an actual sign that was put up. Thank you. Next slide, please. And we describe symptoms of historical trauma when we teach about historical trauma. And we see how this relates strongly to the previous discussions on adverse childhood experiences and trauma as well. There's this significant relationship between all three approaches that are described here. And once again, this is teachings and learnings that Maria presented, almost, gosh, back in the late 1980s. The Takini Network is a network of people that Maria brought together to teach on the historical trauma approach back in the 1990s also. So I and a few other people are members of the Takini Network with Maria, and we're still bonded that way. Next slide, please. So how do we understand historical trauma? Well, once again, like in ACEs and the previous discussion on trauma, this is how we understand the impact of historical trauma. We have these challenges among our people, unemployment. The unemployment rate on Navajo is 40%, for example. Housing, we have chronic shortages in housing because we become dependent on the American ways of housing, making homes for ourselves. But conversely, we understand other impacts of historical trauma today. One is that we have very high rates of abstinence among our people. We have more Native Americans who are abstinent than any other ethnic group in the United States. There have been a number of studies related to this. But conversely, we have more people who are addicted than we do other ethnic people. So it's a really strange, interesting phenomenon that happens with Native people. A lot more people are sober. We also have a lot more in proportion that are affected by drugs and alcohol. We're seeing improved healthcare, and the good and bad things is a movement towards urban employment. I think about 95%, 75% of our people are now living off reservation. I know with many of our people who live off reservation, they still come home. Home meaning our traditional homelands. We're seeing a major growth in cultural-based services. Last week, I had a chance to see young Native professionals in our field really include urban culture-based activities and practices and service designs that they're working on their native lands. And that's a real remarkable change from 40 years ago when I got into the field. There was very little discussion about culture-based services back in the late 1980s. And over the last 40 years, I've just been really pleased at how our young people are picking up these ways as valuable. Our lands are expanding slowly across native lands, across the United States, and we're seeing more wellness and more healing among our people that creates resilience. That's how we understand the impact of how we understand trauma. Next slide. One of the other impacts of historical trauma and understanding that impact is cultural dissonance in education. Children in educational systems experience cultural dissonance because there's, and we're seeing a lot more debate on this in Indian countries, that our kids, and not only our kids, but non-Native kids, don't learn about the impact of the doctrine of discovery and how that rolls out and manifests destiny on our people. And what we see is a counteraction around not including that in American education. The good thing is that we're seeing more inclusion of tribal history, tribal language, and tribal ways in much of the tribal community schools. So we have a dissonance that has been really significant, I think, across several generations, mainly from the impact of boarding schools. And that has an impact on academic achievement and personal development of kids. And we see this, and historically we've seen low academic achievement among Native students, lowered academic achievement among Native American students. But we're seeing a movement out of that. I think we're looking at college data. We're seeing more of our young people going into college. We're seeing more of our young people getting master's degrees and PhD degrees, I think, becoming more grounded that way. But also conversely, a lot of our young people are becoming more informed and capable at including tribal ways into their education. That's really significant growth and change that I've seen. But
And I know
still,
one, oh, go ahead. I
go
was gonna say,
ahead.
I know one of the points that we moved to, like the notes part said, you know, cultural dissonance may provoke the tendency either to resort to ethnocentrism or abandon inherent cultural values to adopt
Mhm.
those of the school culture in order to achieve success, right? So sometimes being in those spaces and settings, right, we kind of have to, you know, I know the term that's used in a lot of like African American communities, right? Like kind of like, you know, code switching, right? But we do that too, right? Because we have to kind of fit into those spaces and be, you know, what we need to be in a school setting or, you know, academic setting, you know, but that might not always adhere to like our own values or beliefs.
Okay.
I know Teresa wanted to say something and then we'll answer Steve's question.
What you just said, the differential because of the trauma, because of the CPTSD, the chronic PTSD, because of the being in survival mode, the needs-based are, I've noticed with our education systems, even like small tribal colleges, having to cater to those needs. And it doesn't prepare our people for the real world. So when they want to go on to college, they then interpret from their trauma responses that the teacher's being mean to them, not is giving them a hard time. And so their success is hard that way. And the stress levels, the cortisol levels that go up, how to juggle life. So then they abuse, child abuse, depression, things like that, and addiction in response to that. There's up in Manitoba, Saskatchewan area, applying land-based learning and overnight success rates because the style that we learn from, how our brains are innately wired in our beings, is more audio first, our storytelling, and then the visual. We watch storytelling and hands-on with more storytelling in hand. And so we learn in a way, and I think that need isn't getting kind of covered. United States portion nationwide, because that understanding I don't know if is there yet. I mean, what you guys are saying.
Yeah, thank you, Therese. Go ahead, next slide.
Okay, so this slide, you know, again, kind of relates back to what we touched upon regarding like epigenetics. So, you know, the newest research in epigenetics tells us that you and I can inherit gene changes from traumas that our parents and grandparents experienced. And so this adaptive change can be passed down to our children and grandchildren biologically, preparing them to deal with similar trauma. You know, so when we look at this kind of this image here, you know, we have like different elements of how stress, you know, kind of like manifests, right? So in our body, in our mind, different behaviors or emotions. I don't know if you wanted to say anything else in terms of balance begins with creating a path of healing. Okay, that's what Ray just commented. You know, but I think recognizing, you know, kind of where this is presenting can also help us to then kind of look at how do we tap into the strengths and kind of challenge, you know, some of these things that may be coming out as like, you know, these, for lack of better words, you kind of like negative, you know, experiences, right? You know, having like, you know, headaches and skin irritation, or having, you know, a lot of like anxiety and worrying, you know, of different emotional states, or, you know, certain behaviors. Next slide.
Good.
Okay, so how has historical trauma impacted families in your community? How do you guys see it impacting family systems?
I think I spoke on that throughout my comment when I shared it, but the families are definitely broken apart here. And function rates are so high, the normalcies of, down to when I grew up, our filters for
Mhm.
self-respect, things like that, down on this reservation, I see 7-year-olds talking extreme sexual. So in the 80s, we wouldn't have, and we wouldn't even thought about that. It wouldn't have occurred to us. So that,
Mm.
and how does that change relationship dynamics then?
Mm.
And then again, the depression, the touching, the self-worth, the ego issues. So all of that with the wounded ego is that because of the identity issues that all of this has impacted.
Good. Thank you, Teresa. Next slide. The third intervention that comes from the historical trauma model is releasing our pain. And this begins that path of healing that you're talking about, Steve. Finding ways to release that pain that we have. And this drawing is from a Navajo medicine man who contemplated that question about how do we deal with our trauma. Go ahead. Next slide. Becoming more resilient. Resilient is a catchphrase that has become more predominant lately.
Go back. No, go back the other way.
So, and these are 8 steps towards becoming a more resilient person. Resilience is a process. It's not a set point. And when I saw this infographic, I thought, oh, this is pretty cool, because it kind of touches on how we begin to. Don't apologize. Next slide, please. I'm talking to Steve, by the way.
Yeah, and I think he said earlier his laptop's very touchy. It's very sensitive. So.
Well, Steve is a sensitive man, also. So, question, Teresa, to respond to here real briefly.
Right, so it says, discuss how healing practices have positively influenced families in the community.
Mm-hmm.
To me, from what I've seen, now these elders have gone per prophecies that our traditional elders of old would pass away in this time, and they have. But we have elders that one used pipe and the prayers. They understood. They were healing themselves, and they would cry for you. With you. And in that, you would see what you went through, that you were so strong about. You didn't about that this is not normal. This is okay to cry. This is okay to say, ouch, that hurt what I went through. And then you built a filter. You knew you didn't become desensitized to or numb to. You healthy boundaries. They carried themselves in a way of ladies or gentlemen, and we behaved, how we cared for each other, how we cared for ourselves. And so that taught us by example. And we're gone now, but I think that was one of the best gifts that we had in the healing ways and communities, them coming in and interacting with our families and showing us how. And they were residential school survivors themselves.
I see. Well, thank you, Teresa. And Natasha, if you have any comments, feel free to show them to us in chat again. Thank you. Next slide, please. And then we go to the fourth intervention of the historical trauma model, which is transcending the trauma. How do we live in a healthy way that is good for us, so that we live a long, good life, physically, emotionally, mentally, and spiritually. Next slide, please. We begin that healing path, and we do become more resilient, and we're able to take on those traumatic experiences that we have in a good way. I can't resist saying that. Like right now, we're living in a really tough time with a pandemic, and some people are doing good, and some people are not doing too good. with the pandemic, and those that are faring okay, are doing well, are folks who would be considered resilient folks. Resilient. There goes Steve. Yeah. Thank you, Steve, for that reminder, brother. Thank you. Next slide, please.
It's actually funny because one of our programs with our Birth to 5 is resilient with like a Z. And so I have like a shirt that says that. So I like that. And so this question is kind of similar to the last one, but it's more looking at, how have those healing practices positively influenced you within the community? Like how has what you've seen changing in a positive way, how does that affect you and then kind of like the work that you do?
For me, it's living by example, and doing on that, it's a form, I think, of cognitive therapy approach, because you're consistent in this way. So you're turning around your patterns, your thoughts, how you perceive things, and you're living it. And then getting out there as well, part of the culture, having those role models back then who would speak to you and call you on it. And now you have a voice in the back of your head checking yourself.
Okay. And we're a little over time, but we'll get just a couple more slides to go through. Go ahead, Steve.
I think it's just the question slide is the next one.
And
the question slide disappeared. It must have got taken out because of something that was on it. It might have been the reference to one of the other programs or something. But any questions? And then you can show our contact information, that's fine.
So here you have our contact information. If you'd like to get a hold of Santos and myself further down the line, Steve and Teresa and Natasha. Want to reiterate that Santos is a clinician, and as a clinician is really grounded in what we're talking about today. And I encourage Natasha, I see that you're a clinician also, I believe, and Teresa also, and have some dialogue with her, I think, on some of the ways that she's adapted these three principles into her work. But any closing remarks, Steve?
No, I just want to say I'm honored and really enjoyed this. I wish we had a little more time, because the small group like this, some of the best meetings and groups I've had have been smaller ones. So it's wonderful, and just want to thank again Ray and Santos respectively for joining, and for Teresa dropping in at the last minute. I invited her in. I said, come, we have room. So great to have her with us. And Tasha, I know we can't see or hear from you, but I could feel your spirit with us. So that's good. And thank you so much for joining. We're going to broadcast again next month. We'll be talking about substance use disorders and domestic violence with a wonderful guest speaker, Dr. Avis Garcia, will join us. So tune in again, and until then, please stay safe, stay connected, and stay healthy. And we'll talk to you again.
Yeah. Take care, everybody.
Hi.
Thank you.